Good evening, folks. Good evening. Hi, welcome to Ideas at Work and Beyond. And tonight, good old friend of mine, Ivan Alsame, has allowed us to do a live call-in show tonight, and I've got a very special guest. His name is Dr. Ed Volpintesta. Ed, Doc,
yeah.
How are you?
Fine, Bob. Glad you got me back. Yeah.
And you know what? I am really, really excited about the fact that Ivan has allowed us to do a live call-in show.
Really nice of him. Yeah,
it's
appreciate
one thing to do tape shows. It's a whole other thing to do a live call-in show. And folks, we've got the call-in number hopefully on there real soon, 792-4101. And if you do call in, essentially just ask a question, and the doc will hopefully answer the question, and we'll go from there. Now, Doc,
good.
Before the calls start coming, and hopefully we'll get a lot of calls.
And my palms are starting to sweat, Bob.
Well,
yeah, right.
There we go.
Okay. Good.
The bottom line is, I guess we had a little technical difficulty, but I guess we're all set.
We're okay now.
The bottom line is, folks out there are probably wondering, why is healthcare so expensive?
Yeah. Easy question, right, Bobby? Well, you know, it starts when a young doctor, his first day in practice, because, you know, most young physicians, when they finish medical school, they already have like about $125,000 of educational debt, Bobby. So just your first day in practice, you're already behind, you know, the 8 ball. That's number one. Number two, most of our costs in medicine, we can't control them. In other words, you know, you have a staff that needs raises. You got to buy everything from tongue depressors to electrocardiogram paper, and we can't control. So those prices will keep on going up. Our malpractice insurance, right now, my partner and myself, we pay about $30,000, our group, for malpractice insurance. For a small group like us, that's quite a bit of money. We have no control over that. When I first went into practice, I think it was something like $6,000. So go from $6,000 to $30 is a big jump, particularly in the meantime that our income has stayed flat. So there's another expense we have no cost over. Our health insurance, you know, we insure, that goes up. So there's a lot of costs that go up that we can't control. But on the other hand, HMOs regulate our fees, so we can't make up for our losses. HMO says, you know, I can tell somebody I think my service may be worth $100, maybe I'll get $65. And every year that doesn't keep up with inflation. That's the big problem with physicians. And the last thing was, you know, Bob, technology is expensive. When I went into practice, we were just beginning to talk about CAT scans. Now CAT scans, MRIs, PET scans, the laboratory work that we do, those are very expensive items. And, you know, physicians don't have any control over that. And so the patient ends up paying for that in the form of increased premiums to the HMO. I don't know if that explains. That's kind of a simple overview.
Well, let's break it down. Let's break it down. You said something a second ago that your income has remained flat.
Yeah.
Now, why is that? I've got my own theories, but
sure.
I'll listen.
Why is my income? Well, a few reasons. Number one, the way I practice, the way my partner practiced, we haven't. It starts like this. With HMOs, the only way a physician, particularly in primary care, is really going to make out well financially is to see lots of patients in a day. We have limited our practice. We don't run a, you know, it sounds self-serving, but it's true. We don't run a mill. You know, we'll see 18, 19, 20 people in a day. When I first started practice, and I think we talked about this a few weeks ago, I would be seeing 30 patients a day, and it was easier. There wasn't the administrative headache. There wasn't the referrals made to the HMOs and all the double guessing and all that sort of thing. And medicine was simpler. Almost every patient that comes to see me now, almost every patient, needs some kind of monitoring. So we have more diabetics. Everybody needs blood work. If you're on a blood pressure medicine, you have to have your kidneys monitored. So there's more and more of that routine maintenance that didn't exist years ago, Bob. So that's, I mean, I pick on the HMOs, and I'll always pick on the HMOs because I don't like them because they really are an interference with the practice of medicine. But in all sincerity, the technology is part of the cost too, drives the cost higher. And as the technology comes out, I mean, people demand it. I mean, people will come in, I mean, especially where we live. You know, you said a few weeks ago that all healthcare is local, and I love that. And I've used that phrase with my patients, and it really says it all. For example, the great example is Lyme disease. Well, Lyme disease was first diagnosed up in the cause of it was found up in Lyme, Connecticut. That's why they call it Lyme disease. Mm-hmm. But where we live now, everybody who gets a joint pain comes in and they see me and they say, "Doc, do you think it's Lyme? I'd like a Lyme test." Most of the times it's not Lyme. And and if I try to talk them out of it if I don't think it's Lyme. But if they really want it, I really feel compelled to do it. Psychologically, it gives them a lot of reassurance. So that's like, here we go talking about healthcare as local. Mm-hmm. I mean, I had patients who had Lyme. They probably got it somewhere in Bethel. They ended up in California. The doctors didn't know what Lyme was. Wow. They came back home. Mm-hmm. we started them on their medication. So healthcare is local. And that's just one little example.
Let me add to that and ask a question I've been wanting to ask for a while.
This is going to be good.
Well, again, I'm just curious, and hopefully I'm curious on behalf of a lot of the viewers out there as well. The HMOs, if you try and increase your rates, let's say you and your partner say, "Listen, we just can't continue practicing. We have to, put a rate increase," just like the auto body shops or the auto repair shops. They, 1 year it's $75 an hour. The next year there's a posting that says $85 an hour. Now, if you guys increase your rates, do the HMOs also increase do they honor that, or do they say, "Listen, you guys can increase your rates all you want, but we won't pay you an extra dime"?
We may think, good question, of course, Bobby. I mean,
yeah, I'll tell you what, we've got a phone call.
Oh, good.
Okay, let me see if I get this right. Hello, thank you for calling.
Hi, Dr. Bolmatesta.
How you doing? Good. Thanks for calling in.
I enjoyed your letter. I always enjoy your letters to the newspapers, by the way.
Thank you. That's my psychotherapy,
Listen, you recently wrote a letter praising Michael Moore's latest movie, Sicko.
Right.
And I fail to understand why, but in this movie, he failed to address the negative aspects of socialized medicine in Canada and in England. One of the ones being that no one wants to be a doctor in those areas. Personal profit drives the medical industry in our United States. It also encourages R&D in medicine, and they don't have the kind of R&D in the pharmaceutical companies in England and Canada because of that. Are you disappointed that he didn't address one of the most expensive parts of the medical practice, insurance and the lawyer industry? Would you expand on that? Thank you.
Did you say insurance?
The lawyer industry, how it's strangling you doctors.
I'm sorry, did you say insurance and law, did you say?
The insurance companies, I enjoyed in the movie how he illustrates how slimy the insurance companies can be towards doctors, but he didn't address that the lawyer industry is a big expense to our insurance and to our doctors' practices. Would you expand on that?
Yeah, wow.
The lawyer industry.
Oh yeah, my favorite topic. Probably out there.
Thank you, caller. Thank you.
Probably out there right now recording this conversation. Well, you raised a lot of good topics, but let's zero in on the law. There's no doubt that, well, you've heard the term defensive medicine. Defensive medicine, and I'll give you an example. When I was a kid, if I fell out of a tree and banged my head, Grandma would give me an ice bag and put it on my head and a Tylenol and make me stop crying, and everything was okay. Today now, if you bang your head, you fall out of a tree, bang your head, you end up in your doctor's office who, because he's worried about a possible lawsuit, however remote it may be. So now you end up in the emergency room with a CAT scan of your son's head. And the point I'm trying to make, and so that the sequence, the cost of that health care keeps going higher and higher and higher. Now, a simple bump on the head may end up costing you $1,500, $2,000. I mean, you know, if you end up in the emergency room, health care is very expensive. They just have to, they have a certain protocol that they have to follow once you're in there, and they're under legal pressure to do the ultimate too. I'm not sure if that's answering your question, but defensive medicine, this fear that doctors have to never make a mistake, to do everything, to offer you the very ultimate in medical technology, is something that's not very, very rarely talked about in the media. It's a real disgrace of American medicine. I had a call from a doctor in Fairfield County a few weeks ago, a general practitioner, and he had said to me, he said, "G.A., you know, I just had a lawsuit." We talked about the lawsuit, and apparently he had done everything right. But he said, you know, my insurance company is dropping me, and I have to go with this other insurance company, and they want $100,000 a year as premiums. He said, I have to get a second mortgage on my house. Now, this is a man who's been in practice for over 40 years, a respected physician, has done a tremendous amount of good for his community, and here he is at the end of his career worrying about taking out a second mortgage to pay for insurance. So there's no doubt that insurance, I mean, it's not the sole driver of healthcare costs, but it sure as hell is a big one. And we don't talk about it enough. And I've been very active, as you know, if you've been reading my letters, I've been trying to get lawyers and doctors together to talk about this, but it's hard. You got two groups who are, you know, diametrically opposed when it comes to how to handle adverse effects. We don't like to call, does malpractice happen? Do doctors make mistakes? Of course they do. We're human beings. But most of the times it's not an error of lack of knowledge. It's what they call an adverse outcome. I mean, bad things happen. People are living older, living longer, getting more chronic diseases. They're getting sicker when they get sick. And all that raises the exposure and the liability for physicians. And if things don't get better, and they're not, you know, you're just going to get less and less people going into health care. As a matter of fact, I'm a primary care doctor, and ever since the HMOs have taken over and forced many primary care doctors to see more patients because their fees are so low compared to, let's say, specialists, as they see more doctors, their liability is exposed because they're just simply seeing greater numbers of patients. So the inclination to make an error is greater. And we have seen the malpractice rates for physicians, primary care doctors, rise precisely for that reason.
Let me ask
I got a little long-winded on that, but hope that answers some of it.
You know, as a listener, let me sort of get clarification on a few points for the viewer out there. So what you're saying, or what I'm hearing, is that the reason healthcare costs are higher and higher and higher and escalating exponentially is, number one, you've got the cost of technology, and that's an exponential increase.
Absolutely.
First reason. May not be the primary reason, but it's one of the reasons.
Significant.
Number two, as the caller prefaced, the defensive costs of practicing medicine are also exponentially increased. And that, again, is relative to the litigation costs,
yes,
or to the protection of your practice from malpractice claims.
Absolutely.
Okay? The third reason is the HMOs. Is that a factor? And what I'm asking here again, before the caller came on, Doc, I just want to get some clarification. I get the feeling that the HMOs will only pay you X amount of dollars for a procedure.
Right. No matter, and I don't know, you know, they have their formulas and their committees where they determine these things, Bob. Mm-hmm. See, it all starts with the employers. In this country, ever since, well, let's see, I guess in the early 40s is when when employers or corporations started to offer insurance to their employees. Back then, it was cheap. You know, they had Blue Cross and Blue Shield, right? Blue Cross was for the office, Blue Shield for the hospital. Mm-hmm. But that was in the 40s. I mean, God, I could remember our family doctor coming to the house and giving my brother a shot of penicillin, And you say, how much was that, Mrs. Volkman tested? It was $2
Wow.
for a shot. You know, when I first started practice in Bethel, my office visit was $8.
Mm-hmm.
And
Yeah, you still
I
made
felt
money.
guilty then, $8, you know.
Yeah. But you
And
still
now-
made money. I mean,
Huh?
you know, you still made money.
But I still made money.
Right.
Yeah, exactly. Well, I made then what I'm making now.
Right.
This is 30 years ago.
Right.
So do the HMOs make?
Are they keeping your costs or your revenues down because they'll only reimburse
Oh,
you?
they're definitely keeping my revenue. Oh, yeah, all doctors' revenues
Right.
down. Some more than others.
Right.
And you know, the argument's always made that primary care doctors don't do procedures. When you come to see me, it's mostly you, me, my stethoscope, my tongue depressor,
Right.
my so I make diagnoses. You know, I make the diagnosis, but I don't take out gallbladders or brain tumors or deliver babies. Those are the big, the big price items. And the reason why they're so expensive because those physicians have tremendous malpractice insurance, much more greater than mine. I think obstetrics is like over about $100,000, $125,000 a year. So that obstetrician's got to see a lot of babies, deliver a lot of healthy babies
To cover that
to
cost.
cover that kind
Right.
of cost.
Now, you mentioned Blue Cross Blue Shield
Right,
was a prevalent health care package 40 years ago.
right.
What was Blue Cross Blue Shield? What did it consist of? You know, it had two names to it, so it sounds like it had
Right.
two components. You know, or was it one
Well,
component?
I don't know. Blue Cross, I think it was one component. I
Really?
think it was one.
Oh.
I think, Bob, and I
So,
think,
I mean, did one side cover the primary side,
Oh, I
primary
see what
care,
you're saying.
and
Oh,
the
yeah.
other side cover the hospitalization?
yeah, that's exactly what it was. Yeah, Blue Cross
Right,
took care of the office.
right,
Blue Shield took care of the hospital cost.
right.
And a lot of people who couldn't afford Blue Shield, in other words, they would go and see the doctor and they would pay for that out of pocket. And they could only afford the Blue Shield that would take care of them if they had their appendix out or a woman delivered a baby. So, and I think it worked pretty good. I mean, I think it was easier for the doctor to take care of an indigent person. You know, times were easier.
Yeah.
The malpractice issue wasn't there yet. Doctors were very rarely sued, particularly the family doctors. That all started about in the 70s and 80s. It's funny, as the technology progressed, people expected more, and they put doctors on a higher pedestal. So when you had that bad outcome, they got mad at the doctor. And right away they thought it was incompetence. I'll give you a great example. During the Civil War, when they couldn't, soldiers were getting their arms and legs blown off and or cracked and fractured, and the doctors couldn't do a very good job. I mean, all they could do was reset the bone and hope things got better, or they would cut a leg off or an arm off to prevent infection. And then as soon as the orthopedist became better at taking care of these broken limbs, then patients started complaining, well, you saved my arm, but gee, it's crooked. And started suing the doctor. So,
Right.
That's crazy, right? Now you've got an arm, it's a little bit crooked. A couple of years before, you wouldn't have an arm at all.
Right.
So the more our technology progresses, the higher we're kept on a pedestal. And the more people expect perfection from us. I mean, again, I'm making it simple. I'm trying to give you these examples and give something for the public to think about.
You know, speaking of the movie Sicko,
Yeah, Sicko.
just speaking about that movie, with respect to the healthcare crisis, and I think there is a healthcare crisis
think
in this
so.
country.
Sure is.
And I think what we're really facing is a growing healthcare crisis. It may be bad for a certain segment of our population now, but it'll be worse if we don't do something about the
Yes.
problem in the future. So what can doctors do, or what kind of programs are you looking at, or are your peers looking at that would ease some of the crisis, ease that crisis from your perspective, from the physician's side of the aisle?
Well,
Hope I'm not hitting you with a hard one
you
here.
hit me with a hard one, Bob, and I'm gonna. I'm hiding my sweaty palms here tonight.
We can brainstorm through it. Yeah.
No,
because I have an idea.
Yeah.
And I'll just throw it at you.
Yeah, go ahead.
Okay. There are programs out there that catastrophic plans. I think Golden Rule is a classic.
Oh,
one.
the health plan you talk. Oh, yeah.
Well,
okay, good. Go on.
I'm leading up to an idea. Why can't universal health care is a hot topic right now. And it's pretty obvious that we're not going to jump into it full bore, even if it is enacted by the, the federal government or the state government. Is there a possibility that we can enact a program that's stepped, in a sense where the government would step in and give primary care or guarantee primary universal care? Because we've had conversations where it's pretty obvious that, for the most part, 80% of the ailments that you have can be handled by a primary care clinic, a primary care physician. Right. The other 20% have to be funneled out or referred to a specialist. Now that I could be off on my numbers, but I'm trying to make a point here.
Right, that's good.
Right.
Good question, Bobby.
So I mean, if 80%, and I want to just make an interesting point and see whether or not I'm on base or off base. If 80% of our health care issues can be handled by a primary care physician or clinic, okay?
Yeah.
And only 20% by the specialized physicians, okay? Theoretically.
Sure.
Yet 20% of the specialized fields more or less represent 80% of the costs because they are so expensive in their specialty.
Right. Yeah, you're not off base. You hit a home run, Bob.
You know what? Save that thought because we've got a caller. Hold on for a second. That's the one thing about live that we have to get used to, okay? Hello, thank you for calling Ideas at Work and Beyond. Can we help you, or can the doctor help you? The doctor's in the house.
Yes, I know that.
Okay, good.
I would like him to address the high cost of prescription medications.
There you go, Doc.
That's a nice, easy question.
Oh, okay. I thought it was a hard question.
The high cost of prescription drug. Yeah, see, that's one of the things that doctors, unfortunately, don't have any control over. I can give you the pat answer that usually is given is that the drug companies will say something like, well, listen, we spend a lot of money on R&D, meaning research and development. They spend millions and millions to develop a new antibiotic, a new blood pressure medicine. And, and that's how they defend their high cost until you get a generic. After several years, the patent goes out on the drug, and and generics will appear on the market at considerable savings. But there's really nothing that a physician can do. I wish there were, to bring the price of drugs down. Sorry.
Well, we've had conversations about this where drug companies will come to you constantly. It's like a revolving door, and they'll try and give you free samples of new drugs. How do you handle that?
Well, they're in and out of the office all the time, Bob. New drug comes out, and oftentimes you don't even know that the new drug's out until they, make their pitch, and they do a good job. I mean, they have a new drug that they want to introduce into the market, and maybe it may or may not have benefits over a pre-existing drug. What do I do personally? I like to let a drug stay on the market for about a year before I use it. I've been in practice 33 years, and during those 33 years, there have been 2 or 3 drugs. And it's just been intuitively that I didn't use and did end up creating problems that were taken off the market. There was an antibiotic, 2 anti-inflammatory drugs that had to, cause, they think, pretty sure it caused deaths or liver damage. So what I usually do is I'll listen, and I will usually let it be on the market for about a year. And when I see all the results are in, and I think it's safe, then I'll use it. So that's my plan. Yeah, that's always in the newspaper. They'll come in, maybe they'll give us a pen or something. There's always this criticism that the pharmacies are whining and dining the doctors. And again, the 3 decades I've been in practice, I've probably been to, 5 or 6 meals at local restaurants. And usually they're giving you, again, pitching a new drug.
Now, the caller does bring up an interesting issue. and maybe this is what triggered her call. We don't know, but I'll just
Yeah,
take
go
a
ahead.
stab at it. Because as you were talking, I'm sitting here going, you know, I would say that the doctor has some control and/or awareness of what family of drugs, you know, let's say you need an antibiotic.
Sure.
Now, there's name brand drugs and then there's generic.
Right.
What do you do in that situation? Do you usually try and save the patient money by giving them a generic,
Oh, absolutely.
without compromising the
Yeah.
treatment regimen?
I think most of us are sensitive to that, Bob.
Right.
I mean, I'll tell you, in the past 6 months, I've had more and more people coming to me who don't have insurance. People who used to be my patients, they moved out of the area. They said, "Gee, doc, I'm back. I'm back home. Would you take me on? I don't have insurance yet." So I see more and more people like that, and who sometimes, I want to start a medicine on them, but I'd like to do a blood test too, and they can't afford the blood test.
Oh my God.
So I tell them, I say, listen, I can give you a break on my fee, or maybe not even charge you if somebody's really destitute or really that hard up, and you've known them for a long time. You got to help them out. But I tell them, but when you go to the drugstore, the drugstore is gonna charge. So I try to give them a generic and at least control their costs that way. So yeah, that's one way we can help out. And I think most doctors are sensitive to that. Because the newer drug, well, I can tell, treating blood pressure, for example, every month there's a new blood pressure medicine. And yet, there's really just a small handful that are effective. The same thing with diabetes. Every month there's a whole, when I started practice, there was just a handful, 2 or 3 medicines plus insulin we used to use for diabetes. And you're always hearing now that there's an epidemic of diabetes in the United States,
Right.
And the studies show that despite all these new medicines, the final outcomes aren't really that much different. It's just a small handful of medicines that are really effective.
Well,
Yeah.
that's an interesting point, because my follow-up question to that would be this. If there's only a small handful of medicines that you might label as tried and true,
Yeah.
medicines that have worked for the
Yeah.
last 10 or 20 or
Yeah.
15 years or whatever, would it be safe to say that the more established medicines are cheaper than the ones that are coming out, brand spanking new, that have millions of dollars worth of research that they have to pay off before they can start making money on them?
Some of them, I can give you the name, a generic name. When I first went into practice, we used to always use a drug for blood pressure called hydrochlorothiazide. Very cheap. We call it a diuretic. Helps to get salt and water out of your system and helps to bring blood pressure out that way. And then for years it fell into, no one used it. It just fell into disapproval. People didn't like to use it, and I'm not sure why. I think it's because of all this plethora of new medicines that came on the market. So we use these new, more sophisticated drugs. It didn't really help that much more, not all of them. And so now we're going back to the hydrochlorothiazide.
Okay, guess
Very
what?
basic drug.
We've got to take a little break.
Okay.
And then we'll be back, folks, in about 5 minutes or so or less. And I think the next thing on the board here is a little news and a little weather from our in-house weatherman and newsman. And we'll see you back in about 3 or 4 minutes.